Thank you. So that's why I work. Second slide, please.
Okay.
Next slide, please. We have no disclosure. Next slide. So just to, by way of the definition, just we know atopic dermatitis is actually a chronic pruritic inflammatory disease that occurs primarily in children that affect adults. Next slide, please. Next slide. In terms of epidemiology, I think we just want to emphasize that the increase has been, there's been an increase in epidemiology around the world since Second World War. And if you look at data from South Africa and Nigeria, I found that in South Africa, I think in children, there was 70%. In Nigeria, it's 15.5%, but actually the Nigerian data is hospital-based. But roughly in the world, depending on which population you're looking at, you are looking at between 10 to 20%. Next slide, please. Next slide. Okay, in terms of pathogenesis, I'm sure the last talk, sorry, can you go back one more slide behind? Okay, I probably not just, I know the last talk talked a lot about this, but I just want to emphasize that it's multifactorial, it's complex, and the fact that the genetic and environment factors in combination, and like I emphasize, the in and out mechanism seems to be the major thing. The filaggrin deficiency, the SPINK5 deficiency, and this immune dysregulation is a major problem. And the fact that the exaggerated T2 response, and that's basically what we're looking at our mechanism. So I don't want to belabor this because the last speaker speaks to this. Next slide. Next slide, please. Well, this is more complex, but just to emphasize that there are a lot of things going on. Then the risk factor for atopic dermatitis. No, next slide, please, Ali. I think she speaks to this initially. The last talk speaks to this. So the risk factors for atopic dermatitis is actually family history of atopy. You usually find that high concordance rate in monozygotic twins, and there's clusters in families. Then there's mutation of filaggrin gene is also a major problem. The gene hypothesis, I think, will be alluded to in other talks, that the cleaner your environment, the chance that you're going to have atopy because your T1 immunity is redundant. And formula of study has been done. If you're from isonomic class or small family size, you tend to have at risk of atopic dermatitis. And then the curious thing that's been observed in some clients is that if your water, the mixed water you use in having your bath, is hard, that has a high level of calcium carbonate, then you are at risk of having atopic dermatitis. Next slide, please. The next slide, please. So in terms of clinical presentation, usually atopic dermatitis usually starts before the age of 2 months, 8 weeks and above. So be very curious, and it's not likely to make a diagnosis of atopic before 8 weeks. So if you see that, then you need to check. You have to look for other things. Maybe you are thinking of a primary immune deficiency that also associated with atopic dermatitis. That's when you see before the 8 weeks mark. So usually the straightforward one you only see after 8 weeks, and there are 3 clinical expression of disease: the infantile type, which you see under the age of 2 years, the childhood variant you see between 2 and 16 years, and the adult and adolescent pattern that you see after the adolescent age group. Next slide, please. So the thing that you need to also look at, the way the lesion present can have the acute phase or subacute or chronic phase. The acute phase is what you tend to see in children. You have a lot of pruritus, you see erythematous plaques, vesicles, you can see pustules, and then you have exudation and crusted because of secondary bacterial infection and all that. But in the adult and childhood type, you tend to see more of subacute and chronic pattern. You have the pruritus, dry and scaly skin, lacutation because of the thickening of skin. You can see fission because of scratch marks, excoriation, and you can still see erythematous purpose. So this you tend to see, these are the primary lesions you see. Let me also emphasize that atopy is primarily a clinical diagnosis. And this UK working diagnostic criteria have been validated in many cultural climes. Even in Nigeria, among children, it's been validated at the specificity about 98%, and positive review value is 92%. So if you have a child that has pruritus or 3 or more of these signs, history of rash increases, and that includes the cubital fossa, the face, and the neck, then you should think along those lines. Then other personal history of asthma or allergic rhinitis, that you use in a child that's older than 4 years old. But if the child is less than 4 years old, then you look at the primary nuclear family with history of asthma or allergic rhinitis. Then history of dry skin last 1 year. The onset before the age of 2 years if the child is less than 4 years. And then you look for evidence of visible dermatitis. That means you look for the primary lesion in the flexures and that includes the face, the neck, and other areas. So if you have pruritus and any three of this, then you can make a diagnosis. This slide, I just want to show you how severe the pruritus can be. You can see this child, next slide please. You can see this child digging into her skin, and you can see that she had a widespread disease involving almost her skin everywhere around her. And you can look at the skin of the caregiver that's always smooth. So I can actually use that to compare. But you can see this child has severe pruritus. So in eczema, atopic dermatitis, severe pruritus is a key thing. Next slide, please. Just a couple of pictures to show you. So this is what you see in the Caucasian. You can see the evidence of the rash on the cheeks, and you can see scaliness. You see the erythema that you tend to see in infancy. Next slide, please. So you see, this is a black child with the same reaction, but you can see that the redness is more like magenta or violaceous appearance on the skin of this child. But you can see the scaliness on the forehead, and you can see the Delhi-Morgan fold in this child also. This was one of the minor criteria for atopic dermatitis. But this also show you what this will look like on the black skin. This is another child, but what I want to emphasize is look at the wrist. You can see the rash around the wrist. So you tend to see rashes in infant eczema in the extensor area of the body. You can see the wrist in this child, and this child is still happy because he has a very mild disease compared to the other child I showed you. Next slide, please. So you can see this is the childhood pattern. You can see the involvement of the cubital fossa in this child. Even if you look at the axilla, you can see that there's some darkening around that area. They just show you what you tend to see. And this is more like subacute or chronic pattern in this child with a bigger child. Next slide, the same slide, you can see the involvement of the popliteal fossa. But in this child, in that culture here, sometimes people like to use corrosive to remove the skin, and that's why you have this child bleeding. But sometimes it's severe atopic dermatitis can present like this. Next slide, please. Next slide, please. Then this is just to show you that sometimes you can have a typical presentation. This is a child that's older than 2 years that has the rash in the anterior knee. So you can still have that in the child outside the infantile group. And then the next slide shows the same child, the rash, this same child is actually, you have more lesion around the bum area and other areas are clean. So you can see that in atopic dermatitis. The last in the picture series and the next one, just to show you a child, next slide please, that involvement of the neck can be one of the areas you need to look for. So these are the things you need to look for in diagnosis. Like I said, emphasis is that is a clinical diagnosis, and you can make a diagnosis of atopic dermatitis using the UK Working Party criteria. So how do you score this? I think the last top speaker speak today, you can use CORAD or EASI, or you can use POEM. But for practical purposes, what I do in my clinic, I try to use the bones thing that use the palm of the side of the palm of the hand to, and I say that's about 1% of the palm of the hand. I say how many of the areas involved, so that we can do a quick assessment using the bones, what to use in bones, assessment of degree of bones. You can use that. I use that, and then I'll look at the severity. If you look at the next slide, I'll tell you practical thing that I do in my clinic. So if I use the bones thing, rule of 9, or use the hand of the child as 1% and see how many, what the area involved, then I can decide, okay, this is a widespread disease. And if there's severity, like the picture I show you, that child is actually digging to a skin, then look for extensive skin involvement, thickness, excoriation. Is there bleeding or oozing? Is there limitation of activities? How impactful is the disease in the psychological impact of this child? And a lot of nice sleep. So if I use all that, the surface area, I can decide, okay, this child has a very severe disease, or this child has a mild to moderate disease. So that's just a quick thing to do if you don't have access to, because usually it's CORAD are easily used for research purposes so that you can compare your data. But for clinical assessment, you can use what I've just described in your clinic setting, especially when you have a very busy clinic. Next slide, please. Next slide, please. So what are the things that you can confuse with atopic dermatitis? Seborrheic dermatitis, contact dermatitis, eczema, scabies, tinea, and immunoglobulin disorders like maybe West-Coast syndrome, Nocturnal syndrome, or Appiagy syndrome. So, but I'm sure if you take a very good history, you should be able to differentiate all this. The only caveat I want just especially a lot here is that even with seborrheic dermatitis and atopic dermatitis, there's a cross link, right? I say there's a under the age of 2, there can be a blood thing between seborrheic dermatitis and atopic dermatitis, because you can have a confusing picture. So sometimes if you see atopic starting, the seborrheic dermatitis can linger than more than 2 years, or it can start a little bit earlier and they itch. But most seborrheic dermatitis will not itch. But if you take good history, you have to differentiate all this condition from atopic dermatitis. Like contact dermatitis, there must be something irritating the child's skin that's in direct contact with skin. And more often than not, you might not have, except maybe like acute dermatitis, you'll be able to differentiate that. Next slide, please. Next slide, please. So, in terms of principle of management, I want to emphasize is that number one, education is key. You need to educate your child about what is going on, or your parents or caregiver, and you need to also tell them the goals of therapy. What do you want to achieve? Because you need to don't let them have high expectation. So let them know what your goal of treatment, what you're going to do, and let them the expectation be managed. In terms of avoidance of external irritation, you want to use non-bio detergent if you're using wash machine. And usually I tell my patient not to use detergent, because to actually rinse detergent out of the soap, the clothes can be difficult. So I ask them to use bar soap, which is very easy to rinse out of your clothing. Then a woolen cloth or polyester that will make the person sweat or irritate the skin, you avoid. Sweat or anything that will cause the child to sweat, you tend to avoid. I will speak to outdoor smiles. See, although there are a lot of data that talks about a lot of people with atopic dermatitis have eye sensitization, and you must need to differentiate between sensitization and actually allergy. Uh, but the data is not so strong that you need to intervene in most people with atopic dermatitis. So, but there's enough data to show that they tend to have eye sensation to isosmite. In terms of food allergy, a lot of people think if you have severe atopic dermatitis, you must be allergic to food. But let me say this: don't just withdraw food from a child with even atopic dermatitis, whether severe or not. And I think the talk that was given about prevention of school allergy will be very informative. There are things that will suggest food allergy playing a role. Number one, from a history. If a child takes the food, within a few minutes to maximum 2 hours, you see a flare up of reaction. If it's IgE driven, and if it's non-IgE driven, then you see the flare up in days and afterwards, right? So the lesson here that if you take a very good history, you will know whether food allergy is playing a role, and then you can do specific testing if it's IgE related, and don't just do a blank testing. I've seen people send results to me that have high level IgE, and those children are eating those food. And like also, we are also told if you avoid food they are supposed to be tolerated, then the food can go through their skin and they are sensitized, and you're now having to deal with the child with food allergy in future. So in food allergy, not only you need to take good history, and if there's no strong history for food allergy, establishing the thing, don't establish the symptoms, and don't avoid food. Antihistamine is very useful, not because it has a role to play. If you look at the possibility that we just described, but we tend to use the sedative antihistamine, the first generation antihistamine, primarily because of the sedative effect. We want to sedate them so they can sleep better at night. Bathing using soap substitute is very encouraged, especially aqueous cream. I'm sure very common in South Africa setting. And in the past, we used cell-adult bath, but now the evidence shows that bathing is encouraged, and that can actually reduce the load, the bacterial load on the skin. Bleach bath or vinegar bath. Let me talk about bleach bath. Bleach bath, if there's evidence of strong second bacterial infection, or you are struggling controlling your child and you think staph aureus is a problem, you can use bleach bath. I was at a conference sometime last year, and some people are putting up with the use of vinegar bath. You can use apple cider bath, but the strong evidence for that, when I researched, is the fact that if you have hard water in your neighborhood, then you can add vinegar, 2 cups to a bathtub, and that will also reduce the pH of the water, and that will help with not disturbing the acid mantle of the skin. And that's the strong case for vinegar. You can use apple cider. And bleach bath, like I said, you use normal like jade or normal chlorine-based bleaching products that are available in the stores. But the way to do that, if you are using full bathtubs, you have to add half a glass of water of bleach into that. If you are using half, you can use 1/4 of that. And then the other rule of thumb, if you're using, if it's a smaller bathtub, you can use the rule of thumb for every teaspoon of bleach, you can add to 1 gallon water. So that can be the rule of thumb you can use. Wet wraps is very useful, especially if you have a child with difficult to control and they're scratching their body. What wet wrap does is to moisturize the skin and to also provide some form of occlusion, and that increase absorption of your steroid that you're going to use. We're going to talk about that. Then you need to provide some psychological support for your kids. Surgical treatment is still steroid. Topical steroid using a fingertip unit. I'll show you a slide about fingertip unit. And the thing about steroid is still the mainstay for mild to moderate. And if you use it properly, you can get them controlled. And then if they're using fingertip unit, you can reassure them that they don't like to overuse the steroid, and the risk of complications using steroid will be mitigated. The other thing also that for everyone taking care of atopic dermatitis, you must have your own mini formulary. You must have a mild steroid, a moderate potent steroid, and a potent steroid that you use. That you know, for example, in South Africa, I know in the public setting, you have Dovate as the most potent steroid that's available. You have betamethasone, Sanala as moderate potent steroid in the public setting, and we have Adherence, the mild potent mild steroid that's available in the public setting. So if you want private practice, you need to have your own formulary, like what I'm going to use for potent, mild, moderate potent steroid, and mild potent steroid, and then you can use appropriately. And then there's also a place for calcineurin like tracholismus and pimecrolimus. It's believed that they has close in terms of strength to moderately potent steroid, and they have their place in atopy. But more often than not, I usually still use steroid as my first line. And if there's steroid phobia and they can afford it, because these medications are very pricey, even in any climate, and then you can step down to that. There's a new concept about intermittent therapy that if you control the symptom and the skin looks good, it's advised that you can still use your steroid daily, twice a week, maybe over the weekend, Friday, Saturday, Sunday, to control or to prevent flare up. So that's a new concept that is being pushed around, and I think there's enough data to support the benefit of using intermittent therapy. Once you have controlled the disease, then you can use over the weekend, apply daily using your fingertip unit over the lesion, and then you get that control. Emollient also has a very big role, like we know, that provide occlusion and also help to trap moisture. But let me say this, there's no perfect emollient. So what you need to do for every patient, try out one, and maybe if you have a choice, if you are working private. But if you are working in public, then you are narrowed. You can't use Gulf. It's all that's available for you if you're working in public setting in South Africa. So this just to show you a slide of what you need to have. So emollient, there's no perfect one, but so try. What I will say to you, if you're working private, try one, and if they are comfortable with it, you can now increase the script and provide one. This also show you that these are class of steroids available. But usually, I would advise that you have your own formulary. What I'm going to use as weak, moderate potent steroid, and potent steroid. That way, you can now choose. So basically, the idea is that for the face and the occlusive area, you need to use very mild steroid, weak steroid. For the trunk, depending on the severity, you can actually start using a very potent steroid. If there's a lot of plaque, for example, you have lichenified skin, you can use a very potent steroid like Dovate, and then you step down to your moderate potent steroid like your betamethasone or your Sinala. So that way you titrate. And then this just to give you an idea of what fingertip unit is all about. You can go to the next slide. Well, the rule of thumb with fingertip unit is that if you press the medication from here to here, then that quantity of fingertip unit should cover the area of twice the size of your palm. So that's also the rule of thumb. So if you don't have to have the chart that I just showed you, you can just say for every fingertip, then the software of the owner of the fingertip will cover the size of your two palm of your hand. So you can actually estimate how many size of palm you can get from the body of the child, and then you estimate what quantity. This also shows you a summary of what I've just talked about if it's correct, if it's scored, you can actually use what to do with refractory disease. So I decided to deliberately do this order of importance. If you have a child with refractory disease or an adult with refractory disease, number one, check adherence. Are they using the medication properly, or are they using the medication correctly? More often than not, most of them don't comply because they also listen to people and say, "No, what you don't go to doctors. There's a traditional way to do it," and I'm sure across cultures, people say that to you. So adherence, number one, before you escalate your care, check adherence, check correct use of medication. Number two, is there any evidence of infection, either staph infection or viral infection? Take care of. If there's staph infection, sometimes you might need to do bleed bath. If it's very overwhelming, you might need to give systemic antibiotics to clear the infection. If you have viral infection, you might need to give viral anti-agents to do that. If you have eczema hepaticum, you need to give a cyclovir, for example, to clear that. Then, if there are emotional triggers, emotional stress, for example, some people have their disease flare up during exams, under pressure, or exposed to irritability, or they use chemical soaps, or overeating maybe during summer with summer period when there is overeating, or low immunity, or dry skin. Like like some people in winter months, they have more dry skin and they can have flare up. So that you need to also identify and mitigate. In terms of, I've actually addressed the food allergy thing. Before you exclude food, make sure you have history suggestive of food allergy. And before you can say eventual allergy is responsible for this flare up, then you need to be sure. If you think there's a flare up on the history, you can modify the environment or do specific allergy testing by asking an allergist to see it. But the key lesson here, please don't avoid food unless you have strong evidence. Then if after you have done all that and there's no progress, then you need to evaluate, have I made the regular diagnosis? Or atopic dermatitis is just a marker or one of the things associated with other condition, primary immune deficiency, for example, might be the result of that. Then you need to look like that. So second line thing, apart from we talk about dupilumab, which is the biologic that's available, that's actually lines for atopic dermatitis. You can use for therapy. Systemic steroid I won't use in a child, but I can use in an adult. Even the modules like methotrexate, cyclosporine, and MMF you can use. But these are things that reserve not for primary care setting. You have to refer to an allergist or dermatologist to put this in place. So in terms of prognosis, most of them were good at disease by puberty. It's rare to see a few people, but it's not very common in middle age. One of the things that I would suggest to you that this child like to have a bad disease. If you have widespread disease in infancy, early onset in earlier age, or there's family history of atopy, and there's presence of asthma, allergies in the same child, like atopy, or being a female, then you know that the prognosis is not very wonderful. Next slide, please. Next slide. Next slide, please. Okay, what are the take-home message from this presentation? Number one, atopic dermatitis is mainly a clinical diagnosis using the UK Working Party. Topical steroid and emollients still remain the mainstay of treatment in primary care setting. So most of these mild to moderate can be taken care of in primary care setting if you do the right thing. Every time you see a patient, check adherence, appropriate use of medication during every follow-up consultation. Routine elimination of food without objective confirmation is a no-no. And when in doubt, refer to a specialist. Next slide. I think that should be the final slide. Last slide, please. So this just to show you that this is what Lagos looks like. So you're invited to come to Lagos and visit us. So this is Lagos. So you can come to Lagos to visit us. Thanks. So I'm done.